Prepare for a longer format, so I made the last minute decision to cut a chunk of it related to the use of TEE specifically for differentiating different types of hemodynamic parameters or hemodynamic, physiologic patterns of CPR, distinguishing between thoracic pump and cardiac pump. For anyone who's interested in that, we'll have a workshop later, and I'll be happy to show you just on a one-to-one basis some of that stuff. But I know that Philip was excited about me including some of the TE stuff in this talk, and I actually think that it's better to keep it simple and give you the fundamentals. And I gave this lecture about 4 years ago, or an early version of this lecture 4 years ago at a emergency medicine conference. And about a year ago, I asked someone in critical care with the assumption that some of the concepts that I'm going to mention here were already kind of old and widely accepted and sort of known and incorporated in practice. And it was interesting to see that asking around to several friends and colleagues that work in intensive care units specifically, in 2019, when a patient goes into cardiac arrest in a unit that has monitors, and even when a patient perhaps has an invasive monitor and like an arterial line in place and end-tidal CO2 connected, in most places or many places, physicians will sort of automatically default to ACLS and go check for a pulse and do exactly the same things that we do if the patient wasn't in that monitor, in that setting. And that just tells us that there's been sort of a collateral effect of coming up with this one-size-fits-all approach that the ACLS provides us. So I want to discuss the approach that our group has been pushing forward for the past several years. Most of the work on hemodynamic-directed CPR has been done at University of Pennsylvania by Dr. Sutton and Dr. Fries and Morgan and group of the Children's Hospital of Philadelphia, a pediatric group that has now translated some of this work to the adult world. And disclosures have not changed for the last hour. And it's important to start by saying that in the current algorithm of ACLS, we treat all patients with the same approach, with the same algorithm, regardless of their underlying physiology or their differences. We just all give them the same. Everyone receives CPR, everyone receives epinephrine, and when indicated, defibrillation. And we basically go between these things, we circle between these therapies over and over and over, expecting to get ROSC eventually. And by doing that, we imply that we're expecting a different outcome by maintaining exactly the same therapy. And that just doesn't make any fundamental sense. That's the definition of insanity, to expect a different outcome by doing exactly the same thing. So we're doing CPR. In order to understand why we do CPR, as I said before, it's important to refresh our memories in terms of what that is accomplishing. Every single of these therapies, chest compressions, epinephrine, defibrillating, everything is directed to optimize the systemic flow. And we do that in order to improve myocardial flow, because we know that that is the main determinant of ROSC. And obviously at the same time, we want to perfuse the brain. And it's with that in mind that the American Heart Association and European Resuscitation Council have defined standards, quality metrics that our hospitals and centers are uphold to. And those are the ones that hopefully you're familiar with: chest compression depth and rate. And unfortunately, there's several studies that demonstrate that we don't, even when we have ACLS-trained healthcare providers, in a significant number of cases, we don't perform CPR according to those metrics. And over 37% of cases is too shallow, and 28% of cases we're going too slow, and all sort of variations of that as well. So why are those metrics just not good enough, fundamentally? And the reason that I think they're not good enough, and our group believes they're not good enough, is because they're provider-centered parameters. They are metrics that were defined, that were made up to satisfy providers and to have something to follow as healthcare providers. They were not really designed having in mind what was optimal for the individual patient that you have in front of you. So just to give you one example, tying back to what I mentioned earlier, this patient was receiving chest compressions determined by guidelines, was receiving chest compression with a 5 centimeter depth. And so this is the contrast that I want to point out. And Dr. Max Harry-Weil, considered by many the father of critical care medicine in the United States, said over 2 decades ago that performing CPR without having measures of the effects is just like flying an airplane without an altimeter. And following Dr. Weil's analogy, we could say that if we wanted to come up with the ideal resuscitation altimeter, one control that would tell us what the chance of success in our resuscitation is, that would be myocardial flow. And that's because CPR success depends on generating appropriate myocardial flow. But unfortunately, in 2019, still, we don't have a way to measure myocardial flow in real time. How cool would it be to have a non-invasive tool, for instance, or even invasive, that gave us a measure in real time of myocardial flow? So what we have today, the best surrogate that we have is a coronary perfusion pressure. It's the pressure of our coronaries determined by the late part of diastole. And we can estimate the coronary perfusion pressure. We can know it by subtracting the right atrial pressure, or the equivalent of CEP, from the aortic diastolic blood pressure. During downtime, there's no flow or no gradient in pressure. As soon as we start doing CPR, we essentially generate an effective pressure gradient by raising the aortic peak pressures. And that pressure gradient is the effect of CPR and is what creates coronary perfusion pressure. And so you could know this number in real time. You could integrate this number in your monitor, in your ICU, to have in real time a coronary perfusion pressure. You have a CEP transfused from a catheter and an A-line in place. You could have that number, and I argue that that should be one of the parameters that you have in a patient that is hemodynamically unstable in case that patient goes into shock, or goes into arrest. So we know that the CPP is the main determinant of survival in CPR. And in fact, we've known that for a long time. We've known it for many years. I'm gonna explain that in a second. But so, if we know that the coronary perfusion pressure is the main determinant, are there any other surrogates that we can use, any other parameters? And I'd like to categorize this in physiologic parameters and performance parameters. And the performance parameters are those that are provider-centered, that I mentioned in the beginning, that are described in the guidelines. And then the physiologic parameters, I think we can categorize them between direct and indirect. And arguably the most commonly used indirect measure of cardiac output is end-tidal CO2. And among the quote-unquote direct measures of myocardial perfusion, of course, perfusion flow is not the same as perfusion. You know, John and Neil Kenny's having a stroke in the back. But you know the idea. Generally speaking, you can say that the coronary perfusion pressure and your diastolic are good surrogates of direct myocardial perfusion. So I want to center on, or briefly discuss, the end-tidal CO2 as an indirect measure that we have widely available in most resuscitation settings. The end-tidal CO2 was validated by different groups back in the 80s. Weil and his group correlated that end-tidal CO2 during resuscitation had a linear correlation with cardiac output in patients with cardiac arrest, and then Sanders made the same correlation between end-tidal CO2 and coronary perfusion pressures. So theoretically, right, the theory of this is that when we start doing CPR, we can identify a waveform of end-tidal CO2 and somehow guide the quality of CPR. Perhaps low quality CPR will be indicated by lower numbers of end-tidal CO2, and that perhaps the most widely used or talked about benefit of entitled CO2 is as a marker of ROSC. We're performing high quality CPR as pointed out here, as described here, and then we have a spike. And this spike was mentioned in the guidelines. This abrupt rise in entitled CO2 has been defined or described as a surrogate of pulse. So theoretically, we could use entitled CO2 to replace pulse checks if it really worked as well. And the problem why it doesn't work that well is because it's fundamentally a measure of pulmonary flow, of pulmonary output. And therefore, is determined, and there's several confounders, including the type of ventilation, including the presence of VQ mismatch, for instance, an underlying PE that could be contributing to the arrest of the patient. We know that it varies with the etiology of the arrest significantly, and we know that it also varies with the length of downtime. We know that it depends significantly on the time of onset of CPR, and therefore, the quality of CPR is just one of many measures or many elements that is affecting that number. So it's just not good enough to allow us to follow it for quality of resuscitation. And for the purpose of detecting ROSC specifically, it is also not great. Several studies have looked at this and have described, as you see here, great variability in the sensitivity and specificity, and that's probably explained by those confounders that are not accounted for. So coming down to those two direct direct measures of myocardial output, myocardial perfusion, coronary perfusion pressure, and diastolic blood pressure. We know that this is a main determinant of CPR success for a long time, and that long time is actually 110 years, or 114 years now. It was in 1903 or 6. Sorry, the Crowell-Angoli, this is sort of seminal study where they grabbed a bunch of dogs and they studied what was the optimal coronary perfusion pressure to get ROSC, to get resuscitate the dogs, and they concluded that study. Again, over 100 years ago, that the coronary perfusion pressure that they needed for those animals was between 30 and 40, and that they needed 1 milligram of epinephrine as the ideal infusion to achieve CPP. Just pause for a second and think about the fact that Garvin Perkins conducted the massive Paramedic 2 trial for several years until last year, using 1 milligram of epinephrine, because this guy's over 100 years ago decided that that was the adequate dose in beagles. Literally, the reason why we use in 2019 1 milligram of epinephrine every single year patients is because it was the right dose for these beagles. It's just incredible, right? Many people in the resuscitation science world think that it's just not the right dose, and that the way that we give it is just not the right way either. Several years later, several decades later, in the 90s, Dr. Noam Pardis and Manny Rivers conducted this study that Rory mentioned as well, where they basically validated the fact that by placing arterial catheters and central venous catheters in Intra-Arrest patients, they confirmed that coronary perfusion pressure had a high predictive value for ROSC, and that you need a number of 15. And this number of 15 has been confirmed in several other studies. We have obtained similar results in studies very recent, both in animal and humans. And the conclusions back then was that the coronary perfusion pressure not only had a positive predictive value, but that the higher the coronary perfusion pressure, the more likely that you will get ROSC. So it seems like a pretty good physiologic parameter. But can the coronary perfusion pressure actually guide the resuscitation better than that recommended chest compression depth? The answer is yes. In 2013 was the first study. Since then, there's been several studies, not just by Bobby Sutton's group, but many others, assessing the effect of the capacity of coronary perfusion pressure to determine ROSC and comparing head-to-head to quality metrics. And this one study was an animal study. They randomized those 3 groups, something like realistic HA care doing 33 millimeters, optimal HA care doing 5 centimeters, 51 millimeters, and then a hemodynamic group that received epinephrine only as needed to titrate a pressure, a coordinate perfusion pressure of 20, and the chest compression depth was targeted also to a systolic blood pressure of 100. And as you would expect, they also demonstrated that that hemodynamic directed effect had better ROSC. In the same group, years later, confirmed that in 24-hour survival and improving neurological outcomes, with better neurological outcomes in animal models. Based on that data at the time, the American Heart Association actually came out with a consensus statement that was endorsed both by the American College of Emergency Physicians and the Society of Critical Care, recommending the use of physiologic monitor during resuscitation. And the parameters that they recommend are these, based on that available data. So you have an arterial line in place. You should target a diastolic blood pressure of 30, at least in your patient. And the same group, as I said, confirmed that there was also a benefit of 24-hour survival, not just ROSC. A few years later, the group of Get With The Guidelines did a large observational study analyzing over 23,000 patients with cardiac arrest in hospital, and compared those patients that had received resuscitation under guidance of end-tidal CO2 or diastolic blood pressures, and they demonstrated that the group that had used hemodynamic guidance had better radius ROSC. They did not demonstrate better hospital discharge or favorable neurological outcome. Rory. Okay. It wasn't great, but there is a signal there, and I think the take-home point in 2018 is that we should be doing this. Is that we know that this leads to better chances of getting ROSC, and that this is currently recommended by the society guidelines. How do we do it? Well, I can tell you how we do it. We have successfully implemented a protocol to place arterial lines in every cardiac arrest, and we learned that in order to do that, we needed to have an orchestrated choreography. It needed to be always the same side. It needed to be a determined provider that is a senior resident or an attending, because it's challenging to cannulate the artery to place an arterial line during CPR. But by having the trays open, both arterial and central venous catheter open, be ahead of time, and the sterile prep also over a table, and having again that provided designated with that task ready to go when the patient rolls in, coming on the left side of the gurney, having the mechanical CPR device ready to be deployed, and having specific roles including TE and airway also assigned, have all contributed to successfully perform intravenous monitoring, invasive monitoring for arterial line, for blood pressure in the majority of our patients in cardiac arrest. So this is for sure feasible. I want to finish with some words of Robert Sutton from an editorial a couple of years ago. They say, we can no longer accept an algorithm where all cardiac arrest patients receive the same treatment. A patient-centric approach, and personal medicine approach is the future. Our patients need resuscitation now, and resuscitation scientists and rescuers alike, including us, should be feeling the pressure. Thank you.